All right, so we're going to go ahead and get started talking about pelvic fractures in the geriatric patient population. My name is Samir Mehta. I'm an orthopedic trauma surgeon at the University of Pennsylvania. I thought I would start off with a little bit of orthopedic humor, although some of you might think this is the reality, and in some cases it might be. But we're usually not this off base. Having said that, I think we start off with something relatively simple, right? Everybody knows what to do with this, right? This is a fragility fracture in an elderly patient. The debate or the dilemma around how to manage and treat this is fairly straightforward at this point, right? We know that these patients have to be treated with some kind of surgical fixation so they can be mobilized and weight-bearing immediately after surgery, right? We know that time to surgery and time to mobilization matter for geriatric hip fractures. The real quandary becomes somebody like this. She's 65 years old. She had a fall. She does not have a femoral neck fracture or an intertrochanteric hip fracture, but she does have a fragility fracture of the pelvis. She's been unable to bear weight for 3 days, yet we treat this patient very differently than the patient who's got a geriatric femoral neck or a geriatric intertrochanteric hip fracture. And the question becomes why, right? We've done a tremendous amount of advancements in the management of geriatric hip fractures. Most hospitals now have a hip fracture pathway that optimizes these patients' time to the OR, time to mobilization, and time to discharge. But we are a far cry away from that for fragility fractures of the pelvis. And you might say, well, just fix them, right? You fix other pelvic fractures. You do high-energy pelvic fractures. You do lumbopelvic dissociations. Just put some screws in them or put some plates on them. Do lumbopelvic, which is a very extreme sort of surgery involving spine and orthopedics. Or do a sacroplasty where you use cement in the back of the pelvis. And these fixation options are an option for patients who have fragility fractures of the pelvis. Unfortunately, they are also invasive with a high complication rate. And so the traditional solutions for pelvic ring management of pelvic ring injury may not be the best option for patients with fragility fractures of the pelvis. And as we think about the numbers of pelvic fractures, again, we look back and look at geriatric hip fractures, and the dilemma, the numbers are very similar. We're seeing an increasing rate of pelvic ring injuries, both high energy, but probably more so in the fragility fracture patient population, right? We know that the occurrence is growing annually at about 9%. And in this recent publication, you can see the dramatic increase in patients in patients over the age of 60, right? So under 60, typically that's your high energy trauma, motor vehicle, fall from height, etc. That number is a little bit of a slower growth. But what we're really seeing it is in our older, more geriatric population, the more frail patient. Similar to the data that you would see if I put a hip fracture curve up, it would look identical to this. When we talk about fragility fractures of the pelvis, they come in two forms, right? Form number one is the acute fragility fracture. This is the one where the patient has some kind of acute traumatic event, typically low energy, resulting in pain in and around their pelvis with difficulty mobilizing. They're usually a ground level fall, usually innocuous, and oftentimes, unless you get that CT scan, which is so essential in this patient population, it's often missed. The other group or the other grouping in the fragility fracture population is your chronic insufficiency fractures. These are typically bilateral. They can be very symptomatic. And again, these patients come in with some kind of a complaint. They can have an acute traumatic event on top of a chronic existing insufficiency injury that thereby debilitates them even more. These patients will often describe an entity where they've been going along relatively well and they've lost sort of function and mobility, and they'll complain of pain that's very focal and very local over the posterior aspect of their pelvic ring. And so when we spoke specifically on the fragility fractures of the pelvis, when you look at these numbers, the incidence rate, the fact that the majority are female, that the incidence is rising, that these are associated with poor bone health, that these occur typically to low energy falls. I could change that title from pelvis to geriatric hip fracture and it would look almost identical with the exception of the numbers being a little bit higher. But otherwise, these two slides go very similar hand in hand. And so these entities are not that different, yet our treatment and our algorithms for these patients are different. There's lots of challenges to conservative care. I can't tell you how many patients are admitted to my own hospital with ambulatory dysfunction, right? There's no home for them, right? They can't go home because they can't physically go home. Orthopedics typically says, I don't want them because there's nothing operative, right? Medicine says, well, they have a medical issue. They don't have a medical issue. Why are we admitting them? And then the ER is sort of left holding the bag saying, what do we do with this patient? They can't go home and nobody wants them. They're the hot potato. And I would say that, again, a decade ago, geriatric hip fractures were like this. They were the quote-unquote hot potato. And now I think a lot more people are taking ownership of these patients. But we know that with conservative care, these patients behave a lot like geriatric hip fracture patients. A high mortality rate, a high length of stay, a high readmission rate, and a high loss of independent function. And we know the other thing that's, again, sort of continues to surprise me is while the incidence is very similar or rising, the treatment methodology is so very different, right? We fix almost all hip fractures that come in. Almost 100% of hip fractures get fixed. Yet, when we talk about fragility fractures of the pelvis, we're talking about 10% or less. It makes no sense because the dysfunction is not that dissimilar. And there are lots of benefits to operative treatment, right? We know that if we fix them, we can get them up and moving. We can get them weight-bearing. We know they have a higher survivor rate, and they have better mobility, and they have a lower risk of complications. And that's true when you think about it. For any frail patient that is immobilized or bedridden, we know that that is going to happen. So it's sort of it's an aha moment, right? Paul Romans in Germany has really looked at this and done a tremendous amount of work. In fact, the classification system is named after him in geriatric hip fractures. And they've used the German trauma registry to really look at these patients critically over decades. And what they found, and really what's really critical, is when you fix these, the mortality rate is tremendously different than if you don't fix these, right? And you can see both for the more simple pattern as well as for the more complex patterns, the mortality rate can sometimes double due to non-operative treatment. And so sometimes I wonder, as orthopedic surgeons, what are we thinking, right? We'll fix a hip fracture at the drop of a hat, yet when it comes to pelvic rings, we're a little bit more standoffish. And I think part of the problem there is it's really hard to fix the pelvis, right? The pelvis is not as simple as a hip fracture. It's not a tubular bone. It's got multiple osseous fixation pathways that are in various shapes and forms. They're not straight lines. And so we try and shove straight screws through what are curved pathways. And so these are the different osseous fixation pathways of the pelvis. These are all the different places you can put screws, but it's not that easy because these pathways are not straight. And so we're either using smaller screws to get through a curved pathway, or we're putting short screws in because we can't get the screws to get through the undulating pathway of the pelvis. And that's where some of the newer and novel technology comes in, like CurvaFix, right? So the mission of this implant is to really optimize our options and improve our outcomes for this particular population. And when you think about this implant, it now allows us to manage all kinds of patients who have fragility fractures of the pelvis to be able to get the implant to stabilize their ring in the appropriate orientation, right? It can be used for high energy bone. It can be used for fragility fractures. It's minimally invasive. It's efficient. It enables safe passage across the entirety of the pelvis. The size of the implant allows us to weight bear these patients immediately post-operatively, which historically we have not done, right? And so all of these things put together allow us to, and I'll show some cases in a second, allow us to be very aggressive with this patient population. So let's go back to our 65-year-old female, status post-fall, diffuse B-cell lymphoma. She's had no lytic lesions to her pelvis. She was walking independently prior to a fall, had no issues, took care of her grandkids. For 3 days, she's been unable to bear weight. She came in. She had a quote-unquote fragility fracture of the pelvis. Here's her CT scan. And this is why it's so important to get a CT scan of the pelvis in this patient population. This is a spondylopelvic dissociation. She's got kyphotic deformity of her pelvis on the sagittal view, right? If this goes untreated, she will then eventually get neurologic compromise of her lower extremities and lose bowel and bladder function. This is a bad entity. And we see a lot of these bilateral failures of posterior pelvic rings in the elderly population with what are relatively innocuous falls. And so the one thing, if nothing else, just get that CT scan while they're in the ER, right? That's the old, if you get nothing else out of this, I think that's really critical. Get that CT, especially that sagittal view, to really make sure that there's no kyphotic deformity like this, because this will progress over time, and this is an unstable pattern. And so for her, we take her to the operating room because it's an unstable pattern, and you can see these wires curving around the nerve roots. So the S1 nerve root is kind of going through that tunnel here. The L5 nerve root sits anterior. These long curving screws to kind of get through the back of the pelvic ring. Here's our post-op CT showing stabilization, and you can see that we were even able to get some of that kyphotic deformity out of our pelvic ring. You say, how did we do it? Through 2 small 1.5 centimeter incisions, right? So this was done percutaneously as a 23-hour admission. So we admitted her, did her surgery, sent her home the next day. This is her 4-week post-op note from my PA. At 4 weeks, at home, doing well, walking independently. 60-year-old female polytrauma patient struck by a car. So higher-ish energy injury, but in a geriatric or an osteoporotic patient. Multiple fractures that you'd expect to see. She had her chest fixed by our trauma surgeons. We started working on her upper extremities. One of the important things for her was the ability to mobilize, right? She can't use crutches or a walker when she's got a right and a left upper extremity that are fixed like this. I mean, she can try, but it's going to be hard to use crutches or a walker or a platform thing. So we took her to the operating room, put a screw in the back of her pelvis. You can see the screw curving across, but she also had an anterior fracture, and it was the anterior fracture that would minimize our ability to allow her to weight bear unless we fixed it. And so you can see this device going in, you can see that wire curving across, and now you can see that screw curving across the front of her pelvis, stabilizing the parasymphyseal fracture that she had. And you can see her at 6 weeks, she's been immediate full weight bearing post-operatively, and you can see that screw coming across and getting that parasymphyseal region, right? So immediate, early weight bearing in what would have been a non-weight bearing patient. These are some references if you're interested. I'm going to show you a couple more cases at the end of these references. So this is a woman. She was transferred from an outside hospital. She had ambulatory dysfunction for 6 days. She had been admitted to the other hospital for 3 days. So for 9 days, this woman has not been able to get out of bed. She has a pelvic ring injury. I don't have the CT to show you, but she's got bilateral posterior ring injury and an anterior ring injury. They've been trying to mobilize her with PT, mobilize her with PT, mobilize her with PT, not working. This is her x-ray 2 weeks after we fixed her, right? So we fixed her. She got transferred to our hospital. We fixed her the next day. She was discharged home, not to a SNF, not to an acute rehab. She was discharged home the day after she got transferred. That's her x-ray from 2 weeks. You can see the screw coming across her pelvis. And this is her video at her 2-week post-op appointment. And so I think that says it all, right? This patient was bedridden essentially for, I think, 10 days, right? And in about an hour and a half, she's been able to mobilize and leave the hospital and go back home. And so I think as you encounter these patients with fragility fractures of the pelvis, I think, number one, it's important to diagnose them. And number two, I think it's important to encourage them to be treated. Our protocol at our hospital is we admit them, we give them 2 attempts at physical therapy or over 2 days trying to get them up and mobilized. And if they're not mobilizing by the 3rd day because of pain or a feeling of instability, we go ahead and we treat them and we stabilize them so they can get out of the hospital, get better, and go on and live their life. You could argue we could be more aggressive like we are with the geriatric hips, but we're working on that process and that data. Thank you. Happy to take questions.